Yeah. And I want to show you a real life example from my own research experience around Simpson's paradox. So I really was keen on doing a good data analysis. So I had to arrange something with my bosses, and then after I did some other work, I was assigned to analyze this study. It was an observational multi-center study of nosocomial infections in 8 hospitals in one province in the Netherlands, the central province in the Netherlands called Utrecht. And all hospitals in this whole province participated. There are 8 hospitals. Okay, we were looking at risk factors for urinary tract infections among gynecological patients. Patients from gynecology, what are risk factors for urinary tract infections? And our special focus was antibiotic prophylaxis. Is this a good strategy maybe to have an influence on urinary tract infections? What would we expect from antibiotic prophylaxis? Probably that it would be prophylactic and that it would prevent urinary tract infections. Okay, so this was our objective. To tell you a bit more about the data, we had from these 8 hospitals, we had data from 3,519 gynecological patients. 279 of them developed nosocomial infections during their stay, out of which 146 were urinary tract infections. So it was with 52% the majority of nosocomial infections. So it seems to be a public health problem, especially if we think that 4.2% of all patients developed a urinary tract infection while they are in hospital. For the people not working in this field, especially when I'm telling this to people who are not medically trained as well as you all are, they say, oh, my God, this is really high rate. For people working in this field, it's 4.2% is not really much. They are having very good hygiene control. Nevertheless, it is a big problem. It's a problem which we wanted to understand. Okay, so what did I do? Exactly as you have now been trained to. I just draw my 2x2 table with all these patients from all hospitals, and I get an odds ratio of 0.7 with a confidence interval of 0.5 to just under 9. I just rounded. So it is a significant result. So what does it say? In the bivariate analysis, I see that antibiotic prophylaxis is a protective factor for urinary tract infections among gynecological patients in these 8 hospitals. Perfect. So I could stop the study, or what would you say?
I have to search for the confounders and the effect modifiers.
Absolutely, you're right. This is a nice start, but we really need to look whether other factors do play a role. And yeah, so of course I was eager to do this. So I first thought maybe there are differences in the hospitals. Let's put the 4 best and the 4 not so good hospitals together and stratify by hospital. Maybe this plays a role. That's what I did. And suddenly Bart Simpson, nice guy, very cute, but really always disturbing, turned up, and we saw this result. So in hospital 1 to 4, we have a relative risk of 2.6, which is significant, and with hospital 5 to 8, we have a relative risk of 2.2 with a significant confidence interval. First of all, do we see anything strange here? Do the stratified results deviate, Aida, from the
when in total they have a certain trend. But when they are separated to each hospital, it shows each have a single its own trend. So that by adding all together, they will give a different result than from separating each study, each hospital.
Right.
And this is indirectly I think the definition of the Simpson's paradox, that usually there is a if groups they have all there will be a trend if they are all together, but if we separate them, each would have their own trends.
Absolutely. We're coming to Simpson's paradox in a minute, but what does it mean? Like, is it, Anshu, is this a confounder?
I would like to think so, because from protective, it has moved to more than 2 times risk factor
And
when we are
the
separating the
important point is, as I said before, and I need to repeat obviously a few more times, if this is a crude odds ratio, if we now stratify and both arms go in one direction and clearly deviate, then we talk about a confounder. Yes, we have a confounder here. In this case, the confounder turns it from, shows us, turns it from protective to now risk factor, which is, as Aida said, a fact indication for Simpson's paradox. But more importantly for us at the moment is, yes, it looks like hospitals distribution might play a role, and it looks like a confounder. Iffy.
Yeah, yeah. If it sounds better. Okay, I observed the difference in the confidence interval. Does that have?
Yes, what do you need to know from the confidence interval? Actually, the confidence interval for us is mainly interesting to see, does it include a 1? And if it doesn't include a 1, it would mean that one end is on the left side and the other end is on the other side of 1, which means it could mean everything. It would not be significant. And for our analysis, it tells us like, this does not include the 1 and those as well, not. They are all bigger than 1 and this is smaller than 1. So it means like, yes, these results are not due to chance, very unlikely due to chance alone. That's all it matters at the moment. And Hatem?
I don't know if I'm right or wrong, but I was wondering if we do further stratification of the stratified hospital, this will be also a confirmatory.
Absolutely, you're right, Hatem. I get your point. Like, maybe I did just a wrong grouping of 1 and 4 and 5 and 8. You're absolutely right. We should take care of maybe all 8 hospitals. I could stratify by 8 hospitals. Yes, that's very good thought. This is also was my thought, my next thought, which I did. And there's a way you can either have 8 or you can do a so-called mental Hensel weighted relative risk, which means like all 8 straight are taken into account and you get an overall result. It's nicer to demonstrate in a way. But that's exactly what I did, what Hatem suggested. And now the relative risk is not 2.2 or 2.6 anymore. Now it's 3.5. Is this any better? Does it fit better in our understanding? Not really. It looks also again confounding, but how can it be that antibiotic prophylaxis is a risk factor? It's a high risk factor. My God, how can this be after taking into account of hospital factors? The next logical step would be, and was also for me, to think about maybe there are other factors also influencing it, like for example, age or risk of procedure. Maybe older women or younger women or whatever have a higher risk, and this is only due to the age distribution because of my sample, or the risk of procedures. Something was really invasive surgery also leads so much more to urinary tract infections than other procedures. So what I did is what I just mentioned before. You can also use a logistic regression model, which takes into account hospital factor, age, and risk of procedure, and of course, antibiotic prophylaxis is the factor of under investigation. So taking all these other factors for which I had relevant data into account, the odds ratio becomes 5.3. Even worse. Bart Simpson is really playing tricks here on us. How can it be that antibiotic prophylaxis in the unstratified shows us what we expect, and in the better and better, the more precise we look, the more difficult it is for us to understand, because antibiotic prophylaxis becomes a real risk factor. Aida, you've got a point.
Why don't we do like the factors that you mentioned, the age and risk of each hospital, see each hospital's conditions and try to figure what was the cause that made this difference?
This is a very good moment, also indicating again a thing I think I mentioned before, but I want to highlight again, is like, what do we normally see in hospital when we do an epidemiological study? We ask patients for potential risk factors, or we measure risk factors like in which hospital was this patient treated.
And the cause of admission?
Yeah, exactly. But what I want to say is like hospital then is an indicator which we can count easily. We can have a look at which hospital was this patient. But hospital means lots of things. Means like not only the antibiotic prophylaxis procedures which they're using, the environment, different. It is an indicator for lots of factors. So this is what we often have, that we can measure indicators, good, but we don't know whether it's the name of the hospital or something which is happening there. So it's difficult, and we need to be aware it's not the hospital, it's something with hospital procedures and conditions there. But obviously it seems to play a role if we stratify for it. Aida, please.
I am so sorry. Just just to figure, the cause is the nosocomial, the anaphylaxis for this. It caused the UTI, or they were admitted for another issue, and they got UTI as a nosocomial infection.
No, they were not admitted for UTI. They got it as a nosocomial infection. But still, the question is really, I mean, how can a prophylaxis be such a major risk factor? That's what I didn't understand at that time. And I know it's confusing. That's okay if it's confusing at the moment. For me, it's the most important factor is that we realize, hey, there can be, confounders can play a role in so many different directions. Now we have the hospital here in these results, the hospital factor is eliminated. And you know, these other factors are eliminated, hospital and age and risk of procedure. And still antibiotic prophylaxis seems to be a high risk factor. So a confounder cannot only give you the impression that there's a risk while there is no risk, like smoking, alcohol and lung cancer, but it can also, the confounder here, hospital, did hide the results because we saw no association or even protective factor here. So obviously there seems to be a confounder. We'll talk about the details after Anshu's questions.
Sir, I'm not able to understand the semantic things first. Second, in this logistic regression, we have taken out a hospital thing and we have analyzed rest of the factors. But with this 5.3, how can we know that which one is like playing, let's say, which one is 2, which one is 3, and then combined they are making it 5, like.
Now, this would go beyond, but believe me, it's something like like the computer program takes into account the influence of all different factors. So it's not with a 2 by 2 table, we have it's more or less one-dimensional, no, two-dimensional. With stratification, it becomes three-dimensional because these factors influence each other. You remember this triangle. And if you have more factors, 4, 5, 6 factors, it becomes then six-dimensional, which is difficult for us with our brains to understand because we live in a 3, maximum 4-dimensional environment. If you take Einstein's factor of time as a fourth dimension. But the computer can even take a 10-dimension cubic and then judge out how big is the factor independent of this and this and this factor. And this is what the logistic regression model does. And it tells us at the end of the day how strong, independent from hospital, from age, and from risk of procedure, how strong is the association between antibiotic prophylaxis and urinary tract infection. This is what we see, and it seems to be big. That's all. So there seems to be a problem. What I want to show you is like this result is even better than what we saw before, because this takes all these factors into account. And what I wanted to show you is like you should stepwise analyze your data. Nevertheless, you can identify sometimes really strange things, like in this case. And that's what I want to explain what we see. The extreme form of confounding is called the Simpson's paradox. This is an extreme form of confounding because results of the data analysis in every mutually exclusive stratum or subgroup are the opposite of the crude result. The crude result is protective, and now we analyze in whatever way we take into account of other influencing factors, and it becomes a risk factor. So what Aida said right early in this example, yes, this is not only confounding, this is an extreme form of confounding, and where it switches from protective to risk factor. And this is what we call Simpson's paradox. I don't expect you to always to really take too much attention to Simpson's paradox. It's just an extreme form that you might want to have heard of. Here you see again, the crude is protective and all strata are turning around and become a risk factor. So Simpson's paradox. But how can we explain this? So I think after long discussions with lots of really wise people from all over, from actually almost all over the world, at that time, I finally can tell you how this can work. It works because we have at least two confounders here, which influence the results in two different directions. The crude, so we've got one confounder pushing it this way, one confounder pushing it the other way. If we use our crude results, they just block each other. So they eliminate each other because of whatever, they're both equally strong probably. Now we stratify and take away the factor hospital. Whatever hospital stands for, lots of this factor, this confounder, we take away. So it's gone. So the other one can show its strengths. And that's why this is my understanding of how Simpson's paradox can be interpreted. So after stratification, one confounder is eliminated, the other one becomes visible. One confounder we know, hospital factor, because we have identified it. Relative risk is reduced. So once we take this away, the other confounder could be indication bias, for example, becomes visible and it increases the risk. What do I mean with indication bias? This is pure speculation. It was published in the journal Epidemiology, and I got lots of comments also from Kenneth Rossman about it. It's quite clear, but there must be another factor, and it's probably if many of you are clinical doctors. If you get a new patient and you do examine her and you hear her story, and then you make up your mind probably how to treat her best. And if you feel like she has a higher risk of getting an infection, you might be more likely to give her antibiotic prophylaxis. And therefore, in this observational study, this indication bias, I assume, probably could have played a role, so that actually those ones who got antibiotic prophylaxis in reality had a higher risk for urinary tract infections, because that's why they got the antibiotic prophylaxis in the first place by their doctors. But I cannot prove this because we didn't collect the data for that. And I'm coming back as always, probably the study design was not so ideal to investigate this research question. We had an observational study. We looked what happens in reality. And to investigate whether antibiotic prophylaxis is a protective factor or really a risk factor, is an observational study really good, or would you have an idea how we could better investigate that? Shuruk, I'm sure you know.
Means that we have to conduct a case control study. So it's a cross-sectional, you mean?
No.
It's a cohort.
No. It is a cohort, so no, but
it's historical cohort.
Historical cohort.
No.
We should collect many information as much we can, like to see what is the cause. And
exactly, the problem is we don't in this setting. It's very difficult to tell the doctors like who to give antibiotic prophylaxis or not. But therefore, we would not have to do an observational study, but Mian,
randomized will just
RCT.
Yes, exactly. So obviously, I'm very thankful for my institute in the Netherlands that they allowed me to publish this in a very prestigious journal. Because what did we show with this study? We showed, oh yes, an example of Simpson's paradox in reality. Fantastic, methodologically interesting. But with other words, we showed we had the wrong study design for this research question. And many of these studies would probably not be published, but it's a clear indication, no, this study design was not good to answer this research question. Again, think about study design. Even though you've done a lot of work, have fantastic results, which might be interesting for a methodological point of view or for didactical reasons for us here in the course, but to answer the research question, the study design was quite obviously not the right one. Okay, I know I have confused you a lot, and let me help. I tried to explain one thing which kept me really busy for a long time at that time, was like, how can it be that the same data, which in total for all hospitals show me it is a protective effect. So indicating like urinary tract infection and antibiotic prophylaxis means like more antibiotic prophylaxis, less urinary tract infection, showing a declining trend, protection. How can it be that if I divide it by in 2 groups or in 8 hospitals, that it in all strata shows me, no, it's not protective, it's a risk factor. And this kept me really, really busy for a long time because I wanted to understand it. And but it's not that complicated after all. I think I figured out is, imagine these are all the 8 hospitals, and the relationship between urinary tract infection and antibiotic prophylaxis. More antibiotic prophylaxis in hospital 5 leads to increasing frequency of urinary tract infections because maybe of indication bias. This is the same in hospital 6 and 7 and 8 and 1 to 4 as well. But if I group the whole data, if I put them all in one box, like we started off with all hospitals together, the distribution still indicates the overall tendency is more antibiotic prophylaxis, less urinary tract infections. So in reality, it's not as colorful and well ordered as in my example here, but data can be distributed in this way. So it is not illogical that confounding happens, or even Simpson's paradox happens. Data can show you this. And you, coming back to our course, you are highly advised whenever you do a study that after a bivariate analysis, you at least stratify for relevant factors which you collected as well. Because then you can disentangle this a bit. Then you can get the color into this picture. Without the picture, it's gray and it's only declining trend. But now you get the color. Oh, maybe I should change the slide into black and white and then just show you one and then the other. And maybe it's easier to understand then. Yeah, the stratification, wow, this is a good new phrase. Stratification doesn't bring light, but brings color into your data analysis, because now you can disentangle better. Okay, it's not, I find it very easily understandable, but I hope you got the idea why it is useful to stratify. Okay. Okay, Simpson, Kenneth Rossman wrote to me that it's a logical consequence of failing to recognize the presence of confounding variables. And my conclusion for you would be, never trust your data. All confounders will rarely be discovered. You can never be sure that even though your data shows you this and this, that it is the truth. The truth is up to God, but we want to get close to it, but we can never be sure that we forget about, that we don't know about a confounder, which has never been discovered. So always the data can lead us, and we're most likely to be true. I mean, if many studies show the same thing, like smoking, in hundreds of studies being the cause for lung cancer, okay, I'm pretty sure this is true. But with other factors, we always need to be a bit careful. Okay. Any questions about this? Then let me become a bit more philosophical, explaining why I mean this with color and light. You know, probably you know Greek mythology, Platon in the Republic, the 7th book from 360 before Christ. The Greek mythology, they were really clever, the Greek at that time. And in one way, in this story, they're describing that somebody was kidnapped by some people he had never seen, and he was fixed in a cave, and he could only face the wall. And behind him was a fire, the only light in this cave. And behind the wall, he saw people carrying some things alongside. And all he could see was the shadow on the wall of those things. And this is a very, very fascinating story. And I find it most fascinating because it describes what we're doing in science and also in epidemiology. What do we see? We see the shadow, and we do not see if it's green or red or whatever, what they're carrying. We cannot touch because we can't touch it, so we don't know if it's hard or soft, but we still can get an idea, oh, it's squared somehow. This is what he's holding up there. And this is as good as we get. We can focus and we can see the shadow much better and better, but we can never be sure because we can never touch. That's what I mean. Like we can get close, but we can never be, you cannot be 100%, don't be too convinced about what you found. Okay. Any questions? Or I can leave it here and then we go to the second exercise. No question. Ah, yeah, Aida.
So
Sir, please, like as if being a medical doctor affects the way how to choose or think about the study, like the anaphylaxis, like it's a nosocomial infection, but even so, nobody would give antibiotic unless it is proved there is an infection. So how come they will start with anaphylactic antibiotic? Because like if like a ward got UTI from any they should test the patient, then they would get the antibiotic. So it would not be anaphylactic.
Yeah.
So how to separate our knowledge with such a thing with numbers or literatures, or what try to the logical way interrupting the explanation of it.
No, you're right. I mean, the study is also on was conducted quite some time ago. So at that time we were a bit more reluctant about thinking about antibiotic prophylaxis being too risky. So these days one would be more cautious, but probably I don't think that the doctors, this is also our theory, but I don't think that the doctors were giving the antibiotic prophylaxis for urinary tract infections. I think they were giving them for maybe these patients had other infections as well, or were at risk of, or the procedure was more risky. So if I didn't make it clear enough that I don't think that the indication bias is due to the worry about urinary tract infections. There are other preconditions. It's just, and it's a theory. I don't know why they did it, but this is could be one of the factors which could explain it somehow. But maybe there are better ways to explain it. I'm absolutely open to that.
Thank you, sir.
Anshu.
sir, I would like to comment on that philosophy.
Yes,
So
please.
what you were trying to say that we should not rely on data, just like it is. Being an epidemiologist or the budding epidemiologist, we should not follow the shadows that we see, because shadows are not relevant. We should rather aim at what is the real thing, where is this shadow coming from, in order to get the reality of the real picture than what is being reflected. Is that what you were trying to say?
What I'm trying to say is like, no, I'm just trying to make us realize that we, even though we think and we have good data and we've done good studies, we think we know the truth. But what I think was we should be aware that due to the fact we are limited, we can know the truth, but we cannot be sure that we know the truth. That's what I want to say. It's like, because our measures, the world is so complex, there are so many other potentially influencing factors which I might not be aware of. So it might completely fit into my world of understanding. If I would have lived 170 years earlier, I would have said certainly miasma is the cause for cholera, because it all fitted into my understanding, but I just didn't know that bacteria exist. And that's maybe this risk we run all the time. So we need to be aware, like we are not touching the things. We are looking at the shadow of on the wall, which can be good enough, which can lead us in many ways, but we cannot be sure. That's all I just wanted to say with it. And Mian, you wanted to comment?
Yeah, I was just reflecting on this null hypothesis and when to reject it, because that was, they always say, if you cannot, if at a certain level of confidence, and if that does not meet that, you cannot say the alternative, the null hypothesis is false, but you say you fail to reject the null hypothesis. So that was always bothering me in the beginning, and I think that is what you're saying, that you cannot be 100% sure.
Exactly. Exactly. We cannot prove something. We can just have serious doubts that the null hypothesis is not true. But it doesn't necessarily mean that it's the truth what we see. But we're getting close to it. But we just be aware that we're trying. You might just miss a confounder, and then the data might be completely different. You don't know. Most likely not, but you can never 100% be sure. Just I want to make you aware of that. Okay. So how fit are you? Shall we do the exercise now, or do you rather want to talk about effect modifiers first? Are you fit enough for effect modifiers? Shall we do this first and then the exercise? Because you were talking about it many times before. Still fit? Half an hour? Okay, let's first do effect modifier. Okay. So it's effect modifier. If we look at two variables, exposure and outcome, there can always be a third variable. It could be a confounder, but it does not always have to be a confounder. It could also be an effect modifier, another third variable. Variation in the magnitude of measures of effect across levels of a third variable indicate that there's an effect modifier. Effect modifier is not a bias, or also is not an error. Bias is maybe the wrong word because you think about bias then. It's not an error, it's the truth. It's something useful. Oh yeah, it's useful information, as my slide says. It is so a confounder leads you in the wrong direction. If your effect modifier is just one part of the whole exposure outcome relationship. In the analysis, relative risk or odds ratios differ between strata again, like you indicated in our exercise. Wow, smokers had a different smoking status played a role in the association between sheep feces and Q fever. So how does it work? Effect modifier, there to identify a subgroup with a lower or higher risk, they are very, very useful. To target public health action, it's very important to know effect modifiers and to study interaction between risk factors. Here's the example I wanted to show you. In a case control study, unstratified data, here you look at oral contraceptives and myocardial infarction. And in this study, you see that you've got 1,000 cases and 1,000 controls. And the odds ratio is 4.8. So cases who had used, women who used oral contraceptive pills, were looked at whether cases with heart attack were more likely to have used oral contraceptives than controls. And we see cases where almost 5 times more likely to have used oral contraceptive pill. Ooh, dangerous risk factor. But clever as you are, you always think like smoking can play a role. We've heard this for almost everything. So let's stratify for smoking. That's what we did. And now we see the raw one was around 4.8. And now we stratify among smokers, we see a relative risk of 6. And for non-smokers, a relative risk of 3. Do the results from the stratification differ from the raw? Yes or no? We all see this, yes. But now, in contrast to what we've seen before for confounders, they're not eliminating the effect, or it's not going in, both straight are not going in the same direction, but one is going up and one is going down. How can that be? If a woman, here these are the women who only use oral contraceptive pill and did not smoke. There we see an association. Yes, it's there. It's 3 times as high for the cases to have been exposed than for the controls. And but if you also smoke, the risk even increases to 6 times as much. And if you don't stratify before, you've got a mix of both, so you've got the average result. So after stratification, we become aware of the underlying risk for non-smokers of 3, and an even higher increased risk for the oral contraceptive users who are also smokers. So this risk plus the risk of smoking leads to this risk, because we've got both here. So this is what we call an effect modifier. The third variable, smoking, does not eliminate the original association. The original association is still there, but it's even much higher among the smokers. Okay. What does effect modifier mean? It belongs to nature. It's not a mistake at all. It is great if we find that, because this is something we can report and which helps us to understand much better the underlying risk factors here. Different effects in different strata are the typical thing for it. It's very simple, useful, increases knowledge of biological mechanism. We understand much better now, and allows targeting of public health action. So here, for example, with this knowledge, you would probably highly recommend an anti-smoking campaign among women using oral contraceptives. Okay. So a confounder, in contrast, belongs to the study. It's weighted relative risk different from the crude relative risk. The third variable leads to distortion of the effect and creates confusion in data. Therefore, we don't want confounder. We don't even want to find it. Oh, we need to find it, but then we need to control it. Because either preferably we prevent it if we can in the study protocol. For example, only doing a study with non-smokers, then smoking cannot be the confounder. Or to control it, and this in the analysis, that's what we're used to now, bivariate analysis, stratification, and maybe doing a logistic regression after. So just a few examples at the end about this. The crude relative risk here of our study is 4 in example number 1. We stratify, and both strata give us the result of 4.0. What do you say? What do you say about this, the third variable for which we stratified in this study, study number 1?
No effect?
No effect?
Not a confounder, or not a confounder, can we say?
Not a confounder. Is it an effect modifier?
No.
It's not a
No.
modifier.
It's not a modifier.
Exactly. As Hatem said, it has no effect. So what do we do with the third variable? We maybe report that we stratified for it and it had no effect, and then forget about it, because this does not influence the results here. Very good. Second example. Who wants to have a look at the second example now? It's a bit more clearer.
Also no association.
Sorry?
It's not a confounder. As raised, it's both of them are near to 1. And this means, and even the one with 1.00, it's a minimal like difference. We cannot consider it as an effect modifier.
Okay, Shuruk,
Oh.
you're right in one thing. After stratification, we do not see any effect anymore. So, but the stratification eliminates the effect of the factor which we stratify for. So, in this case, it's not only interesting whether this is there's an effect, but it's always important to compare it to the crude relative risk. Hatem.
Yeah, actually, I wanted to say the same thing about the crude relative risk. So they're both going in one direction, but they are not following the crude. So there is an effect.
Yeah, no, this is confounded. Jennifer, please.
Confounder effect.
Yeah, confounding, exactly, confounding. There's clear confounding, isn't it? Jennifer, what did you want to say?
I was going to say it's having a confounding effect, but it's reducing the risk.
Exactly. So the original, maybe I just didn't understand you well. Maybe you all wanted to say the original exposure and outcome shows no effect after stratification, which means that the third variable here was a confounder, and the exposure, the observed exposure here as risk factor is not a risk factor after all. That's what you wanted to say, probably.
Yeah. So would you say it's a protective factor or
No, nothing. It's
nothing? Okay.
It's not. It's what it shows here. It's confounding,
Yeah.
because, but the original one has no effect really, not really. As yeah, Anshu, you wanted to say something?
Yeah, I wanted to say the same, that originally they don't have any effect, but yes, they have changed the direction from risk factor to almost no association. So
Exactly, and this is a sign for confounding, right? Okay. Wait, who wanted? Yeah, Ebun Miete. What is the third example?
That was not why I raised my hands.
Huh?
That was not why I raised my hands. Bro, you do this whenever I raise my hands, you always ask for the next thing.
No.
Okay.
First, ask your point, but then we come to the third.
No, it's fine. So number 3, it shows that the confounding factors when it was stratified is closer, like the original exposure, which is the crude RR, is 4.0, and when it was stratified was 3.05 first one, maybe for smokers, and 5.2. So this shows that the one in stratum 2 has more effects on the I guess on
Right. With
has
other
more effects to it, and it is a modifier. Can we say that is a modifier? Why the stratum 1 is a confounder?
No, both you always have to look at it as one. So both is one is going up, one is going down. So
Okay.
it's an indication the variable you stratified for is an effect modifier.
Okay.
Okay. Ifeyinwa, what did you want to say? What is your point?
No, it's just she said it already.
Okay, brilliant. Ebun Miede. Your microphone is off, Ebun Miede. Oh, okay.
I wasn't raising my hands.
Okay, sorry. Okay, good. So again, now let's have a look at number 4. Because then I think soon we have clarified it. So the raw is 4, and then you stratify and you get 1.02 and 1.86. The third variable for which you stratified, does it have an effect? And if so, is it an effect modifier, a confounder, or what? Jennifer, what do you think?
I'm thinking it is a confounder.
Right, absolutely. In the real world, I put a little bit variation in it. In the real world, you never have 1.1, 1.0 and 1.01 or so. But both strata go in the same direction away from the crude. And yes, this is a clear indication for a confounder. Thank you very much. And last but not least, what is this? Hatem, please.
Not be an effect modifier.
Right. Because they're going, the thing you need to keep in mind is do they differ? If they don't differ, it plays no role. Do they differ and go in the same direction away? It's a confounder, in which if they both straight go in, or all straight go in the same direction. If they go in opposite directions, it's an effect modifier. Simple as that. It's not very complicated at all. In detail, you can always discuss and go into much more detail, but the principle is very simple like this. Hatem, did you want to add something? You still have your, okay. All right, so, okay. So bias, confounding, effect modification, more or less clear. Okay, so no, and I'll do the last thing at the end. I better let you look at the exercise now. Now we know quite a bit, and now we need. I really would like you to start thinking of interpreting studies, and this is in our second exercise. But Anshu, you raised your hand.
So I want to ask about indication bias. So we find indication bias only in clinical settings where a physician is biased about prescribing the medicine, or we can find it in any other scenario, so like while selecting the controls or in any others.
Indication bias is only is one of many forms how data can be influenced. It was only the thing which came up most as the most likely explanation for our Simpson's paradox in this example. But you can it is one of the many ways how systematically data can be distorted in one or the other direction. So I wouldn't, we're not having an exam, so, but I wouldn't also ask this in an exam. It's just, once you see a problem, you should, or you will, it's unavoidable, try to understand what could be the underlying reason for that. And that's what I wanted to say on indication bias. Okay, so the next exercise is really short, and yeah, it's perfect. I want to give you, there are 5 or 6 studies very shortly described, and you need to discuss in small groups like some of the questions around this. So I think and we're perfect in our timing. We do this, I give you half and I divide you into small groups again. Stop and stop.